All right, so for my project, I did early mobilization for ECU patients. This is for nursing 3043 at Stanbridge University. By the end of the PowerPoint, you will understand the history and implementation of early mobilization, or EM, in the state of California and globally in the ICU setting. The benefits of EM to the patient, the nurses, and the additional medical staff. The phases, according to UCI Los Alamitos Medical Center, needed to safely conduct EM with minimal risk to the patient and the medical staff. And lastly, the savings in time, energy, and money for the medical staff and the hospital. So the purpose of early mobilization is to give the patient the best chance possible at care, being able to return from care. With this, we've seen a lot of studies with the reduction of mechanical ventilation. This is very important because the majority of patients who are placed on mechanical ventilation, 50% of them end up developing some form of ventilator acquired pneumonia. I saw this on the majority of the patients that I had at UCI Los Alamitos. No matter how much care was given, I mean, oral care was done every day, numerous times, every hour. They had these breakdowns of these packs, and the patients were getting them if they were ventilator dependent. And still, some of them, they would get sputum cultures, and they would always come up positive for some bug. Also, too, early mobilization's been shown to increase their survival outcomes. ICU acquired weakness is the result of muscle wasting and has been seen in 40% of all ICU patients. This leads to decreased mobilization of the patient, causing decreases in moving the airway secretions and bowel issues on top of the atrophy. One of the things that I saw frequently when I was at Walter Reed Medical Center is we'd get a lot of guys flown over from Iraq and Afghanistan to this medical center for treatment, and all of them, after they came out of surgery, were developing some form of atrophy. It didn't matter what physical therapy did with them. Without getting them out of bed and getting them walking early, they were going to start developing this atrophy and all the complications that come along with it. It's been shown to reduce the total length of stay. I mean, it saves money for the patient in the long run. It costs thousands of dollars to stay for every single day in the ICU. And on top of that, it costs thousands of dollars to keep a patient on vent every single day while staying in the ICU. So if you could help process these patients out of the hospital in a safe, quick manner, that the patient is able to discharge safely and go home, you're also relieving some of that workload off the hospital staff. So that also saves the hospital money. Not to mention, every time a person acquires an infection, it costs the hospital about $25,000 just for every hospital-acquired infection that a patient gets, and that's per single one. So if they get numerous, the sky's the limit on how much it costs the hospital, which in turn hurts the bottom line, which potentially could hurt the nurses' pay. And then lastly, this has been tested on people of all ages, so it's not like just adult patients can do this or just geriatrics. I found studies that were done with newborn babies, just getting them moving, doing some active and passive range of motion exercises helped increase these children's survival rates in the PICU setting. So what staff is present on an early mobilization team, right? Of course, you're going to have the ICU nurses, right? The medical doctors, the nurse practitioners, the people that are the mainstay for the ICU. On top of that, you're going to have people that are already pretty much on the ICU team. You're going to have your respiratory techs that are coming in and checking the patients on vent. You're going to have the occupational therapists that are helping with the stroke patients develop a plan on how to talk, eat, move again. Physical therapists, they're sitting there helping with the passive and active range of motion with these people, getting them up and walking and helping out in that sense. dietitians, right? Because you can't heal if your body doesn't have the fuel to keep feeding that machine. And then lift teams. Everyone plays an integral part in this, and their staff that's typically already seen on an ICU floor. Okay, so the background and rationale of early mobilization in the state of California. It was first tested at the University of California, San Francisco Medical Center in March of 2010. It consisted of mixed staffing of med-surg staff, ICU staff, and physical therapy. It started with patients as early as 2 to 5 days after they are admitted into the ICU. You have to get the patient stabilized enough to get them up and moving. If not, you're just taking steps backwards. The main goal was to replicate the benefits of early mobilization that was studied earlier by physicians. So, University of California, San Francisco Medical Center had tested this already with physicians and saw good results. So then they wanted to test it and see if they can replicate those same results with nurses and that interdisciplinary team. So the test lasted for about 2 years and was implemented from 9 ICUs to 13 hospitals within that SF umbrella. This study was later adopted across California and developed by other hospitals to cater to the patient population and staffing. We're fairly close to Los Angeles, and San Francisco's patient population is quite similar to the one we have here. Just different people from all different walks of life, different religions, ethnic backgrounds, race, sexes, everything. So San Francisco's study was able to pretty much be replicated pretty easily in the LA and OC area. So going over early mobilization, there are a few people that should not be started on early mobilization. These are patients with impending or active withdrawal of life support, comfort care, or brain death. I mean, they're not going to benefit from it if they're already at that end stage of life. Evolving or unstable neurological conditions, so your patients with strokes. On top of that, elevated ICP of greater than 20, right? You don't want to tilt them up and risk increasing that intracranial pressure any higher than it needs to be. Unstable fractures, can't walk if your fracture isn't stabilized. Hemodynamic stability, so if your heart rate's under 40 or above 30, we don't want to increase that workload, or blood pressures that are requiring the use of vasopressors and increasing dosage, just trying to nip it in the bud. Respiratory instability requiring increases in PEEP or oxygen mode change to increase support prior to activity. We don't want to sit there and keep having to ramp up this guy's breathing if he's having a hard time being stabilized laying in a bed. If we go move him around, who knows, we might not be able to catch that tissue perfusion the way we had it prior. People with pulmonary artery catheters, people with cardiac balloon pump, all or any femoral access because the risk of bleeding, coagulopathy, right? If something were to happen and they were to bleed, if they're not able to stop bleeding, that would be a big problem. Splenic or liver lacerations, once again, because of the bleed out probability. Undergoing a procedure that prohibits activity, they might have orders placed by the doctor, keeping them on strict bed rest for a procedure coming up. Any patient with an unsecured airway, I mean, every patient we had at the ICU in Los Alamitos was very well stabilized. They had all the proper braces and everything that was needed to keep that airway in place for that patient. And then once again, enforce strict bed rest orders by our provider. So the process of EM, it's pretty much a nice flow sheet. It's pretty much Can the patient do this or try this with the patient? If the patient is able to tolerate, okay, move on to the next step. If the patient is not able to tolerate, it gives you a flow on what you should do next in that protocol. So for the first step, if the patient didn't have any of those excluding factors, the next step is to determine if the patient can tolerate sitting, right? Baby steps, protecting the patient, protecting the nurse. So if the patient doesn't meet any of those excluding criteria, they're going to go ahead and sit that patient up with the head of the bed at 45 minutes or at 45 degrees for 10 minutes. This is just to see if the patient is stable enough to tolerate any mobilization or any procedures. So if the patient is unable to do so, the patient is excluded from the protocol and should have passive range of motion exercises performed every 4 hours. Just go in there, help them move their arms and legs. I mean, we're returning patients hourly, getting them up. So just think about it to where every fourth time you go in there, just help move the patient's arms, legs, give them a little twist here and there. And if they could do it actively, even better. Okay. So if they are able to tolerate sitting with that head of the bed at 45 degrees for 10 minutes, then we're going to go and assess if the patient can lift their arms to shoulder height and can they sit unsupported. We made it to this step with quite a few patients that were stabilized following a stroke. Many of them could not lift their affected limb because of hemiparesis to that shoulder, but we were able to at least set them up in a cardiac chair. So if the patient can't hold their shoulder up or sit unsupported, they're considered a phase 1 early mobilization patient, and they should be placed in a cardiac chair once a day, and then passive or active range of motion should be performed every 4 hours. If the patient is not able to do this after 2 attempts, it is strongly recommended that you get physical therapy or occupational therapy involved in this patient's care. Maybe they have some additional tips and tricks to get them moving. If the patient can support that, next the patient will sit unsupported for at least 2 minutes, and they can kick their legs in a sitting position. If they are unable to do so, the patient's then considered phase 2, which allows them to dangle at the edge of the bed once a day with their feet preferably touching the floor if able to do so, and then support their back with pillows if possible. And just like the phase 1, make 2 attempts to try to progress them to this state. If they can't advance, then you're going to get PT and occupational therapy involved. Next, can the patient stand up, march in place, or walk to a chair? If the patient is unable to do so, phase 3, patients should perform standing and bed transfers once a day. Beginning small with weight bearing, transfer to a chair by pivoting, or take 1 to 2 small steps. The nurse should probably support the patient using a gait belt, a walker, a lift. If the patient's a little bit larger, try to get even if they're not larger, should try to get another person in there just to maybe get the other side of the patient in case they're unable to do so. You don't want to risk this patient falling down and having an adverse event. If the patient is able to do that, you're going to go ahead and let them independently ambulate about 150 feet or 1 lap around the unit. If the patient is unable to do that, they're going to be phase 4, providing limited ambulation with assistance each day up to 150 feet or 1 lap around the unit. The patient may use a walker or physical support. The nurse should have a wheelchair following behind them, like we were taught, that in case the patient becomes exhausted, can't catch their breath, just cannot perform the 150-foot walk, they have a chair right there to go ahead and wheel them back to their room. Once again, gait belts should be used with patients who require walking re-education or need to be reconditioned. I would get physical therapy involved. The physical therapist that they had at Los Alamitos was great. She was very active in trying to get the patients up and moving. She'd show up numerous times throughout the day just to help with the early mobilization process. And lastly, if the patient is able to ambulate greater than 150 feet, then they're considered phase 5. And that's about the highest you can get out of the early mobilization protocol. Okay, so the expected outcomes, these are based on studies from hospitals with similar demographics to where there is here. So early mobilization was shown to reduce the average length of stay by 2 days. Patient ambulation went from about 24.6 to 33% being able to ambulate at time of discharge. 35% increase in patients being able to dangle off the bed, being able to sit at the edge and hang their feet off and maybe enjoy a meal rather than being bedridden, which increases the chance of pressure injury. Savings of $28.4 billion annually for the American healthcare system, and reduction in the amount paid due to hospital-acquired infection, which is about $25,000 per infection. So the methodology that I have for getting this right, before you start any study, you should run this through the ethics committee. They should at least be notified and given a heads up that you're collecting and conducting testing. It needs to be approved. Every journal and study I read discuss running this through some form of an ethics committee at their hospital or site just to get approval to do this. The nurse and medical staff should document when they perform early mobilization and should notify the administration if an adverse effect happens. We're already sitting at the EHR doing our charting. If it takes a few extra seconds to just go in there and be like, hey, EM perform, click a box, passive or active, any injury or adverse effect should be documented anyway. The hospital's administration should be working closely with the ICU staff to determine the patient's length of stay, any adverse events that may have taken place while in the ICU, the amount of time that the patient is on mechanical ventilation, and the outcome. I mean, they're already doing the billing to send to the insurance company or whomever. So if they're already tracking that so they can get paid, we can collect that data from them as well to use for finding out if there's any trends of good or bad. It is the ICU doctor and the patient who will make the determination on if they are eligible and willing to perform early mobilization. It's medical. You can't perform anything on a patient that they're not willing to do. So if the patient doesn't want to do it, then that's on them. They chose to do that, and we might be able to educate them and they might change their minds, but at the end of the day, it is the patient's decision whether they want to participate in this or not. Patients who can perform EM but are unwilling to participate could possibly be used as a control group. Data should be collected at a single point of collection, and modifications should be made by a single person who has locked access to an Excel file for mapping any trends. When you have too many hands in a cookie jar, it makes it really difficult, and some people might be more liberal or conservative in that documentation data. So then that could lead to sways in the outcome or the data collected. The more data collected based on length of stay, days on mechanical vent, patient weights throughout treatment, incidences of possible acquired infection or adverse event should be documented. Patient's name should not be collected, but rather the patient's age, sex, and chief complaint that led to the hospitalization of the ICU should be collected, keeping it HIPAA. From there, modifications may be made later to increase the safety and outcome of the patients, as well as determining if EM can be performed by the staff and if a dedicated team for EM should be created. We already have dedicated staff for specialties such as the wound and ostomy care nurses or the respiratory technicians. So we might be able to form a dedicated team that could be used in numerous different types of ICUs, med-surg, telemetry, just to get the patients up and walking a little bit better. So in conclusion, early mobilization could be utilized with benefits to all parties involved. It has the potential to save countless lives, improvement of the quality of life, reduction in the chances of acquiring an HAI, saving the patient and hospital billions of dollars annually, and the implementation of passive and active range of motion, the role of the ICU nurses already incorporated with other evidence-based practices such as frequent patient movements and assessment throughout the shift. Spending that extra couple of minutes could be the matter of decline or recovery, and early mobilization has been shown to be effective in all age groups ranging from newborn children to elderly. Thank you for taking your time to watch my PowerPoint, and thank you very much. Here's the reference page of all the data if interested. Thank you.